Pause for any questions about that. So far we talked all about fats. Main take-home points is the purpose of bowel salts to kind of break down those fats. Lipase can come in, further break down those triglycerides into monoglycerides and fatty acids. Fatty acids can get into the cell. They can be repackaged to triglycerides once again, then repackaged to chylomicrons, then enter the lacteal. Okay, so that is how fats are digested and absorbed. Okay. All right, now I do want to touch on how bile salts are repackaged or repurposed or recycled. So essentially they're made in the liver, as you can see here. They are stored in the gallbladder if needed, and then they're released by the common bile duct into the duodenum. Now, we don't just lose them in the waste, right? We don't just kind of get rid of them. That would be wasteful. And so the body, being the sufficient machine, is going to reabsorb those bile salts in the terminal small intestine. So in the ileum, we reabsorb those bile salts back into the capillaries via the portal circulation. Again, another reason why the blood that's draining from the intestines, from the spleen, from the colon, has to go through the liver so that we can recapture these bile salts, repurpose them, repackage them, and make new bile to be secreted again. Okay, so very efficient in this way, where we can reabsorb these bile salts in the ileum, send them back to the liver, and then recycle them for new bile. Another clinical correlation here, this is why if you have any type of intestinal surgery, any type of intestinal resection, usually if there's any trauma to the ileum, any cancer, tumors, anything like that, you may have to resect a part of the small intestine. And so in doing so, this is another indicator for patients to avoid fat. If you had any part of your distal intestine, any part of the ileum resected, you have a hard time recycling these bile salts, and your doctor will advise you to avoid fats in the diet because of this reason. Okay. All right, so someone just let me know that the quiz has an error with the due date. Thank you for letting me know that. I will go ahead and fix that. So it was saying that it was due yesterday. No, it's gonna be due on Monday. So I will definitely go ahead and fix that after class. Okay, thank you though. All right, moving on to how we absorb some other things. So we're gonna talk about absorption of vitamins, absorption of minerals, and then lastly, absorption of water. So we absorb fat-soluble vitamins, that's A, D, E, and K, in coordination with absorbing lipids. So they can be dissolved in lipid droplets. They can be packaged as micelles, packaged as chylomicrons. We treat these vitamins the very same way that we treat fats, okay? They are stored in fatty tissue, and they can be absorbed along with fats as well. So that's vitamins A, D, E, and K. Water-soluble vitamins, which are all of the others, require special transport proteins. So they are usually absorbed in the duodenum, but then they require some special transporters to kind of move them around and to bring them into the cell and then across into the blood. However, A, D, E, and K, as we just mentioned, are not going to end up in the blood. They are going to end up in the lacteal, as we mentioned, is the case with fats. Vitamin B12, however, which is a very specific water-soluble vitamin, has more of a complex nature. It needs this intrinsic factor that we talked about. And so intrinsic factor must be present in order for us to uptake vitamin B12 and to absorb it into the blood. Anyone remember which cell we mentioned, which cell of our gastric pit was responsible for secreting intrinsic factor? Can anyone recall that? We talked about one specific cell that secretes intrinsic factor. It's one of the cells of the stomach, one of the cells of those gastric glands, those invaginations in the stomach. So someone is suggesting neck cells, and neck cells is not correct, but that's a good guess. That is one of the cells of the stomach. Neck cells are going to secrete mucus and bicarbonate. But the cells we're looking for are the parietal cells. So remember, parietal cells secrete hydrochloric acid along with intrinsic factor. Okay, really important. Moving on to some other minerals here. So sodium we know is reabsorbed because of the sodium-potassium pump. So very similar to what we saw across the proximal tubule cell. So we have the sodium-potassium pump pumping sodium out. That creates a gradient for sodium to come in. Remember, sodium is helping to bring some of our other things in, such as our glucose is coming in with the help of sodium. Our smaller peptides, dipeptides, tripeptides are coming in. Other things that are coming in with that secondary active transport are coming in as means of hitching a ride with the sodium that's moving in. So sodium is moving in naturally according to the movement of that sodium-potassium pump. And then it's also going to drag water with it. We'll talk about water at the very end, but also think about that solvent drag, this idea that water loves to follow sodium. And so that's going to be seen here across the epithelial cells of the GI as well. As sodium moves in, we're going to see other things like chloride moving in as well. And then when all of these solutes move, water can simply follow by osmosis. All right. Sodium is actively absorbed in the jejunum, ileum, colon. So a lot of reabsorption for sodium. It's such an important ion. Chloride, however, passively follows sodium reabsorption. All right. So it's going to kind of be one of those things that can hitch a ride with that secondary active transport to get into the cell and then move across the basolateral surface by facilitated diffusion, very same way that glucose does in terms of what we would have seen on that proximal tubule cell in the kidneys. Potassium is also absorbed. Again, we're not entirely sure of the mechanism, similar to what we saw in the kidneys as well, how it gets into the cell, but then it can move across the basolateral surface and into the blood. It can be secreted when the luminal concentrations are very low. So if there's not enough potassium in the lumen, then we can actually see some secretion of potassium. So this is the same phenomenon that we saw in the kidneys, right? Sodium is always reabsorbed, never secreted. Potassium can be reabsorbed, but then it can be secreted. And this also speaks to this idea that we want to very closely, very tightly regulate potassium levels and never have excess potassium levels. That can be detrimental. And so there must be a way for us to lose potassium, as we saw in the urine, but then also here as a part of the feces, the GI waste as well. So we can secrete potassium if there are low levels in the lumen as a way to lose potassium, but then it can also be reabsorbed if it's not enough in the plasma. Absorption of bicarbonate happens. So we know bicarbonate is absorbed in the jejunum. We secrete it in the duodenum as a means of regulating or neutralizing rather that acidity of the chyme that's coming down from the stomach. So we start secreting it in the duodenum, and then we start reabsorbing it in the jejunum. Now, if there is not enough chloride and we need to exchange it for chloride, we can lose bicarbonate as a means of exchanging it for reabsorbing chloride. So again, depending on how these minerals are in the blood, we can modify how they're reabsorbed in the intestine. And while we are usually reabsorbing that bicarbonate that we secrete, that bicarbonate that we would have secreted in the duodenum, we're usually reabsorbing it in the distal part of the intestine. If there is not enough chloride, then we can kind of sacrifice that bicarbonate as a means for exchanging it for absorbing chloride. Calcium is actively absorbed in the duodenum and jejunum. It needs calcium binding protein or CBP, which is a way that it can bind to that calcium. This is located on the brush border. It's a brush border protein, and that's how we can get it into the epithelial cells. And then it can move across the basolateral surface of our cells by the calcium active pump. Right? So calcium can get across the apical surface with the help of this calcium binding protein. This is one of the proteins on the brush border. And then once it's in our cells, it can get across the basolateral surface and into the blood with the help of active calcium pumps. Right? Ion, we would have talked a little bit about ion in one of our earlier chapters with the blood, but ion is basically absorbed as it is bound to transferrin. This is what we call T-ion. And it forms this complex which allows it to be taken into the cells by endocytosis, but it must have that transferrin bound to it in order to be absorbed in the small intestine. Now we can move it around the body as T-ion bound to transferrin, or we can store it as F-iron in the enterocytes. We can store it in the liver. We can store it in the spleen. We can store it in the bone marrow, but it must be bound to ferritin, and then it's going to be the F form of iron. So we can circulate T-iron. We can also absorb T-iron as it's bound to transferrin, but then in order to store it, we must convert it to F-iron, which is where it's bound to a different molecule, which is ferritin. Okay. And lastly here, water. So water is absorbed as a passive means of following solute absorption, so by osmosis. We secrete about 7 liters of water per day. Remember, water is needed to move things across the GI. So as a means of secreting our pancreatic juice, as a means of secreting mucus, as a means of secreting the stomach chyme, anything that we move into the lumen is usually done with the help of water. So down in the colon, we have to reclaim that water, and we do so passively as a means of following the solute reabsorption. We're also reabsorbing water throughout the small intestine as well. So although we're seeing secretion of water, as a part of the mucus and so on, and the pancreatic juice, we're also seeing absorption of water there as well. But the most important aspect here is that it's going to follow solute reabsorption. So when we move chloride across, when we move sodium across, we move the solutes that create the osmotic gradient for water to simply follow.